I'll get started. Good evening. On behalf of BioT, I'm Nancy Pagan, the Practice Development Manager for BioT. Tonight, as your moderator, we'll delve into the remarkable benefits of bioidentical hormone replacement therapy. Before we begin, I encourage you to direct your questions to the right side of the screen. At the conclusion of our presentation, we will address all questions. Now, without further ado, I'm delighted to introduce tonight's presenter, Dr. Eric Joseph. He's not only a certified hormone replacement specialist, but also a pioneer in changing the landscape of the way medicine is practiced in America. Dr. Joseph, the floor is yours.
Well, thank you for your kind invitation, Nancy, and thanks for all of you that are out there that have taken time out of your busy evening to listen. I'm going to get right to it. The topic of the talk is changing medicine in America. And I thought of that topic because the way medicine is treated today, it involves having a disease or an illness and going to the doctor and getting your disease or illness treated. And from what I've learned over the last 6 months of studying hormones is that as we age, there is a drop of hormones in our body that is grossly underdiagnosed, underrecognized, and easily treatable, and would be suitable for not only for preventing disease, but to help you live your best life and to feel your best. So I'll take the next slide, please. When we talk about hormones, what are they? They regulate your body. Hormones are chemicals that are made by organs called glands. And then the glands secrete these hormones into the blood, and they travel through the bloodstream to target organs. And so specifically with the first two hormones, testosterone and estradiol, those are called sex hormones or gonadal hormones. There are testosterone and estradiol receptors in the brain, in the bones, in the breasts, in the prostate, all over the body. And where are they made? In the male, the majority of testosterone is made in the testes, with a small percent made in the adrenal glands. And in a young woman, about 50% of testosterone production comes from the ovaries and 50% comes from the adrenal glands. And I want to make clear at the beginning that testosterone is not a male hormone and estradiol is not a female hormone. Yes, it is true that male testosterone levels tend to be 10 times higher than women, and estradiol levels are lower in men than women. The benefit of both testosterone and estradiol in the right proportion is critical for the health and well-being of both men and women. The third hormone on the list, and these four, testosterone, estradiol, progesterone, and thyroid hormone, are the four hormones that we deal with principally when we're dealing with disease prevention and anti-aging. Progesterone is strictly a female hormone, and I want to digress on progesterone for a quick second. The menstrual cycle in women is approximately 30 days, 28 days. And the first half or the first 14 days of the cycle is estrogen dominant. The second half of the cycle is progesterone dominant. And when a woman has her menstrual period, it's due to a precipitous drop in her progesterone level. So progesterone, whenever we supplement a woman who has a uterus with estradiol, we always add progesterone to prevent bleeding, because estradiol increases the thickness of the endometrium, or lining of the universe, lining of the uterine rather, and progesterone is what prevents the menses. Progesterone is the hormone of pregnancy. So God forbid if a woman has frequent miscarriages, progesterone is used to prevent bleeding. The fourth on the list is thyroid hormone. That's produced in the thyroid gland, which is in the low neck. And thyroid hormone is principally responsible for our metabolism. It has to do with how hot we feel, how cold we feel. If our thyroid is too high, we tend to be hot, sweaty, and with diarrhea. If our thyroid hormone is underactive, we tend to be cold, clammy, and constipated, and it can also affect the skin and nails. I'll take the next slide, please. Hormone levels decrease with age. Testosterone decreases about 1 to 3% per year in men over age 35. And what really shocked me was to learn that as women age from 20 to 40, their testosterone drops 50%. And that's a significant amount. And we'll get into symptoms of that in a short bit. Estradiol decreases when perimenopause starts. So what's perimenopause? Menopause is 1 year after your last menstrual cycle. Perimenopause is the period of time when estradiol and progesterone start decreasing. And testosterone is also concomitantly going down. And the decrease of those three hormones are the cause of perimenopausal symptoms, which can be vasomotor symptoms like hot flashes or night sweats, and other problems with cognitive ability and mood. Hypothyroidism or underactive thyroid, I'm shocked as to how many men and women we're diagnosing with underactive thyroid right now because we're testing for it. Next, please. So how do you know if you have a hormone deficiency? Number one, you have to look at your brain. Are you exhausted? Do you have mood swings? Do you have anxiety and depression? Are you waking up in the middle of the night, unable to sleep, and perhaps falling back asleep when it's time to wake up? Are you having difficulty focusing on the task at hand? Do you have brain fog? If you have hot flashes and night sweats, that's likely due to an estradiol deficiency. Patients who are low in testosterone and estradiol tend to have a difficult time losing weight. I cannot overemphasize the anti-inflammatory effects of testosterone for joint pain. It could be foot pain, hand pain, low back pain. Just aches and pains generally get better with testosterone. Insofar as bladder symptoms in women, as estradiol and testosterone levels decrease, that can lead to a condition called atrophic vaginitis, which is a thinning of the vaginal membrane. And as women know, the urethra is in the vagina. And if the vaginal mucosa that's next to the urethra becomes thinned, you could imagine that with a cough or a sneeze, there could be more of an opportunity for a leak. Many women have menstrual migraines, which tend to occur right before the menses and are associated with a low level of estradiol. So you could imagine that somebody that has a history of menstrual migraine, as they go through their changes and as their estradiol level continues to decrease, that gets worse. And insofar as desire for sex, testosterone and estradiol replacement definitely increase desire to have sexual relations with your partner. When you come into the office, the first thing we do is we check your blood pressure. I'm a bit of a stickler when it comes to adding anything like hormone replacement therapy. I really want everybody's blood pressure controlled, as some of you may know that are out there that are watching this. And that's easy. And I'm comfortable managing, or at least getting somebody started managing their blood pressure. When it comes to high cholesterol and diabetes, I don't manage blood sugar. Cholesterol lipid numbers can get better with HRT, bioidentical hormone replacement therapy. And I tend to be on the aggressive side insofar as offering a low dose statin just to decrease risks of atherosclerotic heart disease. I always I need to find out if somebody has prostate cancer, breast cancer, if somebody has PCOS or polycystic ovarian syndrome. That's a condition in women that tends to be associated with a slightly higher testosterone level. So there are special considerations in patients with PCOS. Endometriosis is a condition where there's ectopic endometrial uterine lining tissue that gets deposited outside of the uterus, mostly in the pelvis, sometimes on the bladder, and sometimes above the pelvis and the abdominal cavity. And it can be a very debilitating condition, and it's very hormonally sensitive. We like to find out about any medications that you may be taking that could affect hormone levels, like Propecia, which is a medication that some men will take for male pattern baldness. When it comes to the blood work that we get, I want to go into that next, and I'm going to start with the top four. We get total testosterone and free testosterone levels in everybody. We get estradiol levels in everybody, and when we need to supplement testosterone and estradiol, as I'll get into later, I'm a big proponent of subcutaneous pelleting with BioT pellets. The number one reason is that it lasts for between 3 to 6 months in women and men, and it tends to lead to a steady state of hormone as opposed to peaks and valleys. All women with a uterus that receive estrogen supplementation will need to take bioidentical progesterone, which comes in the form of a pill. And that's taken typically on a nightly basis with dinner. Thyroid hormone, if somebody is deemed to be hypothyroid, we utilize desiccated thyroid, and that also comes in a pill, and that tends to be taken in the morning, usually on an empty stomach or with a little bit of food. Next slide, please. We check everybody's vitamin D level. Why? Low vitamin D seems to be the norm from what I'm seeing. Vitamin D is really important for your bone health. And if your vitamin D levels are low, that's a risk factor for osteoporosis, osteopenia, pathologic bone fracture. We want to prevent that. Vitamin B12 is a feel-good energy vitamin, so we check vitamin B12 levels. We check a lipid profile. I thought I'd put this mnemonic to remember the difference between HDL and LDL. HDL and LDL stands for high density lipoprotein and low density lipoprotein, but it's much easier to remember highly desirable lipid and least desirable lipid, because to have a high HDL, that's the good cholesterol, that's protective, and to have a high LDL, that's the cholesterol that leads to plaques in the arteries and causes heart attacks. So that's the difference between LDL and HDL. One is good, one is bad, and in general, estradiol replacement therapy and testosterone replacement therapy can lead to more favorable lipid levels in patients that are suitable candidates. We check ferritin levels in everybody. Ferritin is a measure of somebody's iron stores. By definition, if ferritin is low, somebody has some form of iron deficiency anemia. And because of the relationship between low ferritin, autoimmune thyroiditis, and leaky gut, it's also important for the management of certain autoimmune conditions. PSA is prostate specific antigen. That's always 0 in a woman, and we always check it in a man to make sure that there is no prostate cancer present in a male patient. Prolactin is a hormone produced by the pituitary gland that's responsible for lactation in women after they give birth. Sometimes young men that have lower than expected testosterone levels have what are called benign prolactinomas that are treatable, and that's why we test for it, especially in young men that have low testosterone levels. After we supplement testosterone and estradiol, next to the micronutrients, excuse me, the most important one is the first one, DIM. DIM is diindolylmethane. It's completely plant-derived. It's derived from cruciferous vegetables like cauliflower, broccoli, and Brussels sprouts. And it's that safe, and it's ridiculously important because DIM is important for the metabolism of estrogens, and it's also important for the metabolism of testosterone. I make it a point when I speak about estradiol supplementation to call it estradiol, and estradiol is a type of estrogen. There's estrone in the body, there's estradiol in the body, there's estriol in the body. Estrone and estriol are associated with breast carcinoma. Estradiol is not associated with causing breast carcinoma. So that's a distinction that needs to be made, and DIM helps with the metabolism of the bad estrogens, and it tends to lead to a higher level of the good estrogen or estradiol. Methylfolate is a type of vitamin B. It's folic acid. Since many in America don't have the enzyme to convert folic acid into the active form, methylfolate, we have a vitamin B micronutrient that's terrific that has the methylated form of the folate. ADK is a lovely vitamin D product that has vitamin K also, and the vitamin K helps to get the vitamin D into the bone. And we offer probiotics to everybody. I can't overemphasize how important they are. The gastroenterologists have been talking about the importance of the microbiome or the normal intestinal flora as being important. And to my knowledge, Hashimoto thyroiditis or autoimmune thyroiditis is associated with a leaky gut syndrome and malnutrition, and probiotics, along with a stringent diet, are really the key for success in treating an autoimmune thyroiditis. Just about 40% of men over 45 have a low level of testosterone. I want to talk a minute about metabolic syndrome. Metabolic syndrome is a condition where there's increased belly fat, hypertension, diabetes, hypercholesterolemia, heart disease. That constellation is called metabolic syndrome, and it's associated with low testosterone. And a lot of those conditions that are associated with metabolic condition may be improved by supplementing a low testosterone in a man, because it's linked to early heart disease. And since primary care doctors are not checking men's testosterone levels after 45 or at all, as far as I know, it's certainly underrecognized, underdiagnosed, and undertreated. You can go to the next, please. So supplementation with testosterone, it helps the bones, prevents bone fracture, osteoporosis, osteopenia. It helps the brain. It prevents dementia, Alzheimer's disease, brain fog, memory loss, anxiety, depression. Testosterone prevents breast cancer. It protects the breast from breast cancer. Testosterone prevents the prostate from developing aggressive prostate cancer. There is no relationship between bioidentical hormone testosterone supplementation and causing prostate cancer. Testosterone is, I can't overemphasize the cardiac benefits. One of the benefits of testosterone is that it's a vasodilator, or it opens up blood flow. So somebody with coronary disease, if their testosterone is low and you increase it, you can increase perfusion to the heart. And that's where I believe one of the benefits of this sex hormone lies in helping somebody either not get heart disease or even to improve perhaps their disease condition if they have it. And of course, supplementing testosterone in a relationship is certainly good for a healthy sexual relationship. As I mentioned earlier, T is present in both men and women. The amount of testosterone in a man is about 10 times that in a woman, and about 1 to 2% per year as men age from 30 to 70. That's how much T goes down. But women, they really lose about 10% a year due to a cutoff of testosterone production from the adrenal gland that happens such that between age 20 to age 40, 50% of the total testosterone level tends to decline from age 20 to 40 in a woman. Low testosterone and disease, metabolic syndrome, high blood pressure, diabetes, increased abdominal fat, atherosclerosis, heart disease. Not all of these conditions are going to be treated with testosterone, but since testosterone helps the brain, and not only does it help the brain with memory and mood and preventing dementia, but in my view, it sort of makes the brain think the way it used to think. It thinks differently. You look at sex differently. You look at a joyful life differently. You might be more inclined to go out and walk the dog after dinner than to sit on the couch and watch television. That's one of the many benefits that testosterone can provide for somebody that has low levels. I like the word sarcopenia. I had to look it up when I ran across it. Sarcopenia is the medical term for frailness. And I sort of envision sarcopenia and a frail person as an elderly senior citizen with a walker that's hunched over from osteoporosis. And it looks like if there were a strong breeze, they would probably fall over. That's sarcopenia or frailty that is associated with low testosterone. As you increase testosterone, exercise capacity goes up. Low testosterone is associated with aggressive prostate carcinoma, and it's also associated with anxiety, depression, brain fog, and memory loss, and erectile dysfunction in men. So the benefits of bioidentical testosterone for both men and women include increased zest for life, increased sense of well-being, improvement in depression, anxiety, improved mental clarity, improved memory, better ability to focus on the task at hand without being distracted, more energy at the end of the day when the kids get home from school, an increased desire to have sexual relations. And again, there's a protective property against breast cancer and prostate cancer. Testosterone prevents Alzheimer's disease and dementia. It's protective to the heart. It helps to prevent heart attack. It's a big bone builder. It's the only of the two hormones. Estradiol also is very good for the bones, but testosterone actually increases bone density as seen on a DEXA scan. So women that have a propensity for osteoporosis would be very well served by an appropriate testosterone supplementation, and considering all things about their history considered. T leads to increased bone strength. It definitely increases lean muscle mass. If you use your increased lean muscle mass, you will burn excess body fat, and testosterone can also result in an improved lipid profile. Next slide, please. So menopause is defined by 12 consecutive months without a period or a follicle stimulating hormone greater than 23. It's important. It really is, because we don't give estradiol supplementation until the menopause or until 12 consecutive months without a period. What's important is the perimenopause, where 15 years before you have 1 year without a period, your testosterone starts to go down a lot, estradiol starts to decrease, and progesterone starts to decrease. And the progesterone decreases because during the perimenopause, the amount of ovulation is variable. So if a woman doesn't ovulate, they don't produce a corpus luteal cyst, which produces the progesterone, and which makes them estrogen dominant. That could lead to a particular cycle that's heavy. So there can be variation in intensity of menstrual cycle. There could be variation in duration of menstrual cycle, along with brain fog, memory issues, anxiety, depression, difficulty sleeping during the perimenopause. And most women, I don't think that they appreciate how much menopause affects them. Most point to the VMS or the vasomotor symptoms, the hot flashes and the night sweats associated with low estradiol. But really, as you'll see in the next slide, since the levels of estradiol and testosterone are low, women are more likely to get heart disease. They lose the protective benefit of T and testosterone and estradiol against breast cancer, and they're more likely to have low bone density and mood disorders, anxiety, depression, and memory loss. And I also don't think that many women completely get over menopause and feel as good as they did in their premenopausal days. In a premenopausal woman, the likelihood of dying from a heart attack is 1 in 7. After the menopause, it's 1 in 3. Now, heart attacks are multifactorial. Do you smoke? Do you have high cholesterol? Do you have high blood pressure? Do you have diabetes? Those are big risk factors. The reality is, since hormone levels are not routinely tested, and since estradiol levels and testosterone levels are shown to have cardiac protection insofar as atherosclerotic heart disease and heart attack, low estradiol and low testosterone is one of the significant contributing factors to heart disease in women, especially after the menopause. Next slide, please. As I mentioned earlier, estrogen is not strictly a female hormone. It's in both men and women. It's a feel-good hormone. We do not want a man's estradiol level to be 0. We like it to be around 30. Estradiol protects the bones, the brain, the breasts, and the heart. Just as I've mentioned before, I'm being reiterative on purpose because I want the take-home facts to be clear. Estradiol is the secret sauce for controlling hot flashes and night sweats. And there's certainly are estradiol receptors in the brain. Hence, it helps with mood and memory. And as my patients, as a facial plastic surgeon, will be happy to learn if you came to me from my facial plastic surgery practice. Estradiol is directly related to collagen in the skin. So there's a reason why during the perimenopause, women age. Men age too. Some say men age better than women. I'm not going to be the arbiter on that one. I can just tell you that decreasing estradiol levels can lead to a decrease in estrogen or less tight facial skin. And as I mentioned above, estradiol is a happy hormone. It just needs to be at the right level, not too high and not too low. The benefits of bioidentical estradiol include looking younger, controlling vasomotor symptoms like hot flashes and night sweats, maintaining bone density, increasing bone strength, excellent for the memory, preventing Alzheimer's disease and dementia that is 8 times more common in women. It can improve a lipid profile, and it protects the bones from pathologic fracture, osteopenia, and osteoporosis, the breast from breast cancer, the brain from Alzheimer's disease, dementia, brain fog, anxiety and depression, and the heart from atherosclerotic disease that causes heart attack. Next slide, please. Thyroid hormone is produced in the thyroid gland in your neck. There are 3 blood tests that we get to check somebody's thyroid function. It's T3, T4, and TSH. T3 stands for triiodothyronine. T4 stands for tetraiodothyronine or thyroxine. The reason why I'm pronouncing these words is because T3 or the triiodothyronine is the only active hormone. And so people who are hypothyroid, they're either hypothyroid because their thyroid gland isn't making enough T4 and T3, or because peripherally in the organs are unable to convert T4 to T3 because T4 unto itself doesn't do anything to the cells. Only free T3 is the active hormone. It regulates whether you feel warm or cold, whether you're constipated or have diarrhea. It helps with breaking down and metabolizing fat and decreasing hunger, which is important if you're trying to lose weight. Definitely it prevents dementia, improves cognitive function, and it's good for energy. So given the fact, I would say in our practice, we're seeing 40% of patients that think their thyroid is normal functioning are actually hypothyroid. And we want to supplement thyroid hormone to prevent from the cardiovascular disease, the weight gain, fatigue, the bone problems, and obviously the cognitive issues that occur with hypothyroidism. 35% of all Americans are hypothyroid, and 40% of Americans that come to us in Livingston are hypothyroid, excuse me. Again, it's hypothyroidism is defined by either decreased production by the gland or decreased conversion from thyroxine to triiodothyronine, which is the active hormone, T3. I think it's interesting that synthetic thyroid hormone, Synthroid, or levothyroxine, is synthetic T4. So somebody who's hypothyroid, if you give them levothyroxine as a supplement, it's taking an assumption that they don't have a problem converting T4 to T3. And not everybody checks free T3 levels. So as far as I'm concerned, the free T3 level is the most important level for determining that in the history for determining if somebody's hypothyroid. I want to mention again autoimmune thyroiditis or Hashimoto's thyroiditis because it's relatively common. It's easy to test for with a blood test. We test everybody for it. And it's the other reason why it's noteworthy is that it tends to be associated with a goiter or thyroid enlargement. It can be associated with thyroid nodules. And in somebody who has a diagnosis of autoimmune thyroiditis or Hashimoto's, if they have a thyroid nodule, it's more likely to be malignant in somebody with Hashimoto's than somebody who doesn't have Hashimoto's thyroiditis. And the next line says iodine deficiency with low salt diets. Triiodothyronine. The iodo means iodine. So thyroid hormone is made of a lot of iodine. And cardiologists who are treating patients with hypertension, because increased sodium intake and some people can elevate the blood pressure, the number one way that we get iodine in our diet is through table salt. It's probably about 80 years ago our government started supplementing table salt with iodine to decrease goiter and hypothyroidism. And just around that same time, the government started putting thiamine in cereals to decrease a terrible skin condition called pellagra. And they also started putting vitamin D into milk to decrease rickets, which is end-stage osteoporosis in a child. Rickets is hypovitamin D, low vitamin D level in a child, and it's essentially been eradicated since vitamin D has been put in milk. That said, I'm dumbfounded by the amount of low levels of vitamin D that are present not only here, but in Texas, where the sun shines all the time. So that I don't have an answer for. The autoimmune thyroiditis can be associated with a leaky gut and an abnormal overgrowth of bacteria in the colon. And it also tends to be associated with low ferritin levels. So these are things that we check. And if any of our patients have Hashimoto's thyroiditis, and I just picked up a case of it last week, if anybody in the audience has Hashimoto's thyroiditis, it's a very stringent diet to go on. It's a very healthy diet. So if you're looking to lose weight, it'll get you there. And it'll probably make you feel a lot better because the reality is if you're allergic to a food and it's causing your body to attack itself in the thyroid, you have to not eat the food. A free T3 range from LabCorp or Quest is going to say anything from 2.3 to 4.3 is considered normal. To be euthyroid or normal thyroid, we like the free T3 to be between 3.7 and 4.3 for optimal thyroid function, and that's what we're all about, optimizing our body's functions. So instead of using Synthroid or levothyroxine, we use desiccated thyroid. It's our treatment of choice. It contains both T4 and T3 and is suitable for people who might have problems converting thyroxine to triiodothyronine. Next slide, please. I have to stop here because I have to just make a pause, not stop. When it comes to the difference between synthetic hormones and bioidentical hormones, synthetic hormones gave hormone replacement therapy a very terrible stain that it shouldn't have. The first two under synthetic pills, Premarin and Prempro. Premarin is synthetic estrogen, synthetic estradiol. Premarin is an acronym for pregnant mare estrogen. So Premarin, if you've ever taken it, is derived from a pregnant horse's urine. Prem Pro is a synthetic progestin. So it's like progesterone, but it's synthetic. And all birth control pills that are taken by women orally contain synthetic estrogens and synthetic progestins. And synthetic estrogens are associated with blood clots, deep venous thromboses, and synthetic progestins are associated with breast cancer, but not estradiol. So the synthetic hormones are ubiquitous amongst young women that are on birth control. And I think that I'm not against birth control pills for women. I'm all for education and for women understanding what they're getting themselves into before they start taking it. When it comes to injectable hormone replacement therapy, for the most part, it's testosterone cypionate, it's injectable testosterone, it's all synthetic. I'm not a fan because there's a roller coaster ride with it. It needs to be given twice a week. The levels go up and down. And the reason I can't advocate it is that it increases, like Premarin, like synthetic estrogens, it increases the stickiness of platelets. It can cause a blood clot. The bioidentical, which means your body cannot tell the difference between hormone made from a plant and hormone made from your body. The bioidentical estradiol is not associated with deep venous thrombosis, and micronized progesterone that is bioidentical is not associated with breast cancer. I'm not a big fan of patches, creams, and gels, and most people that use patches, creams, and gels either like them or they don't. The reason why somebody might not like a patch, a cream, or a gel is because some people just don't absorb well through their skin. So a lot of people just get a zero effect. It just doesn't work. There can be variable absorption of a gel through the skin, depending on how hydrated the skin is. And patches unto themselves can cause dermatitis. They can cause redness and inflammation. And so, you know, when you lift the square off, you can end up with a little red square wherever it's placed. And for the long, so I feel that pellets reign supreme, mostly because they're easy to put in. You forget about it once they're in. They're extremely well tolerated by our patients, and it tends to lead to a steady state blood level for between 3 to 6 months. And it's individualized for each patient. This is just a reiteration of what I said. I'm going to go through this quickly. Whenever you take something orally, upper left hand, anything taken orally has to pass through the stomach, which is loaded with acid. So there's always a change when a medication goes to the stomach. This is why some medications are supposed to be taken on an empty stomach. Some medications are supposed to be taken with food on a full stomach, like progesterone in the evening after dinner. And so there's variable absorption from an oral route. An injectable route implies synthetic, which implies increased stickiness of platelets. And there's also other problems where a man's estradiol level could go higher than expected because of increased conversion of synthetic testosterone to estrogen in the patient's fat. And it also can lead to a hematocrit or a hemoglobin that's too high, which is called erythrocytosis. In the lower right-hand corner, when we pellet somebody, the blood levels are stable for 3 to 6 months, depending on whether you're a woman or a man. And it's extremely well tolerated, fast. It's an office visit, and there's no downtime. Again, synthetic testosterone makes platelets sticky. That's my number one issue with it. It can be toxic to the liver, and it also tends to have an opposite effect on somebody's lipid profile. So it tends to make the least desirable lipids high instead of the other way around, where bioidentical testosterone makes the highly desirable lipids high. And some say that injectable synthetic testosterone makes men cranky. Next slide. Next slide, please. So the pellets that we use, the BioT pellets that I purchase are, if you look at the right side of the screen, there's a picture of a hand and there's two small pellets in there. The cylindrical long pellet is about the length of a Tic Tac and about half of the width. And the small pellet looks like a 6 milligram estradiol pellet. And it's just super, super tiny. And I have a very short clip at the end that shows the implantation procedure, which is fairly simple. They're made from soy and yams. It's all plant-based, not animal-based. The body believes that these bioidentical hormones are produced from the body. Um, Bioidentical hormone therapy, hormone replacement therapy with pelleting has an 80-year track record of safety. We implant these pellets usually under the skin of the buttock or sometimes above the buttock in the flank area. Next slide, please. This just shows two studies where back in 1939, salmon treated women with subcutaneous estradiol pellets that had their uterus and ovaries removed. And 10 years later, Greenblatt treated menopausal symptoms with pellet formed estradiol and testosterone. So there's over 80 years of use, safety, and studies in the United States and globally. Human identical hormone is a bioidentical hormone. The brain, the body, the receptors cannot tell the difference. Everybody gets an individualized dose depending upon their blood work and their size, and the implants are placed underneath the skin, typically in the buttock. Next slide. Next slide. Osteoporosis, low bone density, osteopenia, bone fracture. This is a big cause of mortality in postmenopausal women. A slip, a fall, a hip fracture, a hospitalization can lead to an unnecessary demise of a senior citizen. Testosterone has been shown to be the major bone builder, okay? If anybody's had a DEXA scan is a nuclear scan that's used to check bone density. Testosterone improves DEXA scans. Estradiol will maintain bone density, but testosterone actually improves it. And I believe that's because testosterone readily, everybody who receives testosterone is going to feel stronger. You feel the muscle fibers being laid down. And strong muscles make bones stronger because they support the bones. They do more with the bones, and the impact actually causes osteoclastic formation or bone formation. Next slide, please. Next slide. Women get Alzheimer's disease 8 times over men, okay? And women who receive any type of estrogen supplementation during the 50% likely to get Alzheimer's disease. I was shocked to read that statistic. Men who have low levels of testosterone are 3 times more likely to develop Alzheimer's disease. Hence, testosterone is brain protective. Next, please. Estradiol decreases body fat and improves somebody's lipid profile by decreasing the least desirable lipid and increasing the highly desirable lipid. When testosterone is added to that in the postmenopausal patient, there's a marked reduction of fat due to the increased lean muscle mass. And that dynamic duo of testosterone and estradiol protects the bones from osteoporosis, osteopenia, and bone fracture, the breast from breast cancer, the brain from dementia, memory loss, Alzheimer's disease, anxiety and depression, and the heart from atherosclerosis and heart attack. Next slide. In men, testosterone supplementation may also improve lipids. Sometimes statins are necessary. I'm not against statins. I'm interested in getting lipid profiles to where the least desirable lipid, the LDL, is less than 99. and the total cholesterol is less than 200, and the HDL should be nice and high, higher than 45. Testosterone, just to say it for a millionth time, it protects the heart from heart attack. It protects the brain from senility, for lack of a better word. It protects the bones from low bone density and fracture. And it also prevents men from getting aggressive prostate carcinoma. Next slide. Okay, this is my favorite slide. If you look at the bottom of the slide, the x-axis has age from 20 to 60. So you can see that from age 40 to age 60, hormone levels drop. They drop 1 to 3% in a man yearly in a man from perhaps age 35 to 70, that's testosterone, and 10% in a woman up to testosterone from age 20 to age 40 drops 10% yearly. As hormone levels drop, that's associated with low energy, exhaustion at the end of the day, mood swings, anxiety, depression, inability to lose weight, aches and pains, difficulty sleeping, brain fog, loss of desire to live life and to have sex. And it also increases the risk of age-related illnesses like dementia and heart attack. If you look at the top right of the slide, when you're optimized, when your hormone levels have optimized, there's an increase of energy, better sleep, better mental clarity, a better ability to lose weight because your lean muscle mass is a calorie burner, increased desire for sex, and protection against breast carcinoma, low bone density, bone fracture, osteoporosis, and protection against heart attack. Next slide. Nancy, if you could play this and keep the volume off, that'd be terrific. So I'm doing a procedure here. The patient is laying on their right side. I made a small incision, and this is after lidocaine is injected. A small trocar is inserted underneath the skin, and you'll see the inner portion is taken out right now, and there's a little lumen or a hole on the inside of that trocar, and that's where the delicate little pellets are placed. So right now, as things are silent, I'm grabbing my container of pellets with my left hand and my forceps with my right hand, and I'm about to get in place, and you put the smallest pellet first, which is 37.5 milligrams of testosterone, followed by another 87.5 milligrams of testosterone. You should be able to see that pellet, and it just gets slipped in like that. And then the next maneuver is to take the obturator and to push those pellets in underneath the skin. As you can see, this is completely painless with local anesthetic. The entirety of this video from beginning to end is 2 minutes, so the entirety of the procedure takes about 7 minutes. And a stitch doesn't even need to be placed. So right now I'm about to push the pellets in place, and I feel with the opposite hand. The pellets go there, everything comes out, and we put on a piece of tape, and it's Band-Aid surgery. It's easy, and it's something that you don't have to think about taking a cream twice a day or several creams twice a day. And the blood levels tend to remain stable, and we monitor patients' blood work so that everybody gets a dose that's appropriate for them, where the benefits that have been discussed from the beginning of the talk until now are realized without giving too much. And you could see that little 4 millimeter incision, it closes within 48 hours with tape on. Although we do like you to keep a dressing on for a full 5 days, there's very little that can go wrong if 48 hours after implantation, like you just saw. Next slide, Nancy. I think this is the end. Please ask questions. I am at your disposal, and I thank everybody for listening to me tonight. My God, I didn't realize how dark it got. You can't see me anymore. Are there any questions, Nancy?
Let's see. I think a few questions are coming in. Let's see. First question, how do I get started? What would be my next step?
I think your next step, if you've seen me before, give Gloria in the office a call and let her know that you're interested in having your hormone levels evaluated, and she would be happy to send you a prescription. Once the blood levels are drawn, I would then give you a phone call and we could have a phone conversation about them. And if necessary, other than if you don't know me and you need to find out more about this, by all means, we encourage everybody to come in for a consultation so we can, because I need to meet everybody and find out their disease processes, how they're feeling, their symptoms, and then come the blood tests. That encourages me to say what I've been taught many moons ago: treat the patient, not the numbers. So it's always important whenever looking at a blood test, whenever looking at a level, it's always important to correlate that number with how somebody's feeling. So if you don't know me, kindly give us a call and come visit us for a pelleting consultation, and we'll get you set up to have your hormones checked, and then we'll have a discussion from there.
Great. We have a few more questions. When would you check labs again after implantation of pellets?
Excellent question. After a woman is implanted, we get blood work of estradiol, testosterone, and a CBC in 6 weeks. In a man, we check the same in 4 weeks. Since men have 10 times higher level of testosterone than women, a male procedure is a little bit trickier than what you saw in the video, which was ridiculously simple, only because the male testosterone pellets are a little bit closer to the size of a Tic Tac, and a few of them need to be placed more than in a woman.
Next question. How long will it take for pellets to get into my system?
Most patients will start to feel good within 2 weeks. 2 weeks is the magic point where I'd be surprised if somebody said to me in 2 weeks, "Doc, I don't feel anything except the pain in my butt." If that were the case, they would, if it were a woman, or they would get blood work at 4 weeks, and if levels are low, if the milieu isn't right, we offer a boost, and it's a no charge boost. So that's part of the individualized dosing with BioT. You dose today, your blood is checked in a month to 6 weeks, you're checked in a month to 6 weeks. How are you feeling? How are you doing? How's your blood pressure? Hey, Doc, I don't feel so good. I review the labs. If I undershoot and I need to add more, I call it a dose adjustment. BioT calls it a boost. A dose adjustment or a boost is no charge, and that's typically done between 4 and 8 weeks after a procedure, depending on the situation.
Great. That was the question that just came in. And she also asked, what would you do if a female patient were to become pregnant?
I'd say mazel tov. I'd say congratulations.
Right.
The progesterone is a pregnancy hormone. Estradiol is a pregnancy hormone. Testosterone does not cause abortions. It's not advisable to undergo hormone replacement therapy if you're intending to get pregnant. However, and that's a question that we ask, I would advise against hormone replacement therapy if you're planning on getting pregnant. If there were an unplanned pregnancy, I would wish you the best of luck, and I would reassure you that everything is going to be fine.
Exactly. Next question. Will I need to take other medications?
It depends. If you're a woman with a uterus and postmenopausal that's estradiol deficient and will require estradiol, you will require progesterone to be taken daily. And progesterone is a pill that's taken on a full stomach with supper. The number one side effect, which frankly has been reported to me as a bonus, is that it can cause somnolence or sleepiness. So estradiol supplementation and oral progesterone supplementation go hand in hand. The micronutrient DIM is must be taken because otherwise the testosterone metabolism and the estrogen metabolism is going to be off, and it's going to lead to numbers that are less than favorable. Insofar as vitamin D, which we recommend, insofar as the vitamin Bs and methylfolate, and insofar as the probiotic, if somebody is vehemently opposed to taking that, they don't take it. But to take DIM, everybody who gets either T or E, testosterone or estradiol, must take DIM, or they shouldn't do it. And just to reiterate it once more, a woman who's postmenopausal with a uterus that's in need of estradiol supplementation must take progesterone with it. And think about it. It's more physiologic as to how things were when you were younger. When you were younger, you were producing estradiol and progesterone, and most women like how they feel on the two of them.
Great. And do we have two more questions? Will pellets help me lose weight?
That's a great question. It depends on what period of time you're looking to lose the weight in. I would not advocate hormone replacement therapy solely for going on a diet. Hormone replacement therapy absolutely leads to increased muscle mass, increased lean body mass, and decreased fat. But you have to work it. You'll feel less aches and pains. So there really is no good excuse not to make the concerted effort. Plus, the testosterone increases the desire to go for that walk with the dog after dinner. So it's really individual dependent. Unto themselves, muscle weighs more than fat. So since everybody who's pelleted is going to feel stronger, simply by virtue of the fact that the testosterone causes striated muscle, brand new, to lay down very quickly within the first month. You have to use the muscle because your weight will increase in the beginning until the muscle formation stops, and then it decreases slowly. So that, to answer the question, expect to see weight loss with self-control after a year. 1 year. This is not like Ozempic or a peptide or something where you want to drop 25 pounds in 2 months. This is something where we're looking to prevent bad diseases, like we discussed, and we're looking to feel better from a psychological standpoint and to feel better from a physical standpoint. But if you don't utilize the feeling better from a physical and mental standpoint to actually get out there and do it, and go to the gym and get on the treadmill and work out, I mean, it's easy. What type of exercise do you want us to do, Doc? I say 20 minutes on the treadmill in the morning and 20 minutes of lightweight in the evening. If you can, that would be perfect. I'd be happy with a half an hour, 5 to 6 days a week on the treadmill, to the point where you're elevating your heart rate and making yourself sweat. That is how you lose weight with hormone replacement therapy. And it doesn't have to be running. It could be biking. It could be swimming. I'm a big fan of walking because I think walking is the key to longevity, and that's what this is all about. And people who live into their 90s and live to be 100, they're not in a wheelchair, they're walking. So I'm a big fan of walking. I think it's an excellent activity. And exercise is also very good for the brain. It's very good for decreasing anxiety and depression, and it's very good for making people sleepy and helping them sleep better. So if you make a commitment for a better lifestyle that includes hormone replacement therapy with bioidentical pellets, you owe it to yourself to really make a commitment to want to exercise and burn those calories.
Great. Let's see here. At what age can a person begin this therapy?
It depends. That's a terrific question. I would say it depends. I'm pelleting. If you're in the audience, of course, I would never say your name. I'm pelleting somebody on Saturday who had what's called a BRCA gene. And a BRCA gene can increase the likelihood of breast carcinoma and ovarian carcinoma. And many women with a BRCA gene will decide to have a bilateral mastectomy or both breasts removed prophylactically and to have both of their ovaries removed. This is a relatively young lady that did this because she has a family and she wants to stay alive. And it doesn't matter what age you are. If your body is no longer producing adequate amounts of testosterone and estradiol, we just need to know why. For instance, if a male were very young, do they have a prolactinoma? Is their prolactin level high? If it ends up being a low testosterone level, just because that's all the body is able to produce, we would supplement. And if I ever had a question or a major concern, I would potentially consult with an endocrinologist.
Okay, a few more questions. This is great. Are there any contraindications?
Contraindications to pelleting. Yes, there are. If you have active prostate carcinoma, you are not a candidate for testosterone supplementation. If you've been treated for prostate cancer and you're deemed cancer-free by your oncologist, you may be a candidate for testosterone supplementation. That's a little bit of a gray area, but not that gray. At least not to me, it's not. If you have a personal history of breast cancer at any time during your life, the current recommendations are to not give estradiol supplements. I'm not sure there's a great rationale behind that. If somebody has been, let's say, 5 years disease-free, however, it is an absolute contraindication to pellet somebody with estradiol if they've had a personal history of breast cancer. If somebody has a personal history of sensitivity to testosterone or estradiol, some people can't tolerate it. Some people have tried creams or other modalities and they just can't tolerate it. That would be a reason to not give it. I can't think of any other good reasons to not give it, but that's a great question.
Right. And are patients usually on this therapy indefinitely?
I think the answer to the question is greater than 90% of patients that get pelleted end up coming back and returning for repeat pelleting. So there's a very high retention rate. And since we're dealing with decreased estradiol, decreased testosterone with aging, if you've gotten to the point where you're symptomatic, it's not going to get better when the testosterone or perhaps estradiol in a woman is completely metabolized and wears off. It's going to put you back to how you felt in the beginning, in which case the decision is either to get repelleted, or I guess if you like the way life was before, which has not been the case in over 90% of patients, or if you didn't like the idea of a pellet, if you had a problem with the pelleting procedure, which is ridiculously uncommon.
Mhm. Wonderful questions. Last question, not sure that it's relative to this, but what does Prolia do to a man on androgen suppression therapy?
Prolia, I don't know what Prolia is.
Yeah,
Androgen
question.
deprivation therapy. ADT, androgen deprivation therapy, is typically what's given to a man who's being treated for prostate carcinoma. Because once I said a million times that testosterone, bioidentical testosterone, BioT pelleted testosterone, does not cause prostate cancer. However, if you have prostate cancer, and if those prostate cancer cells have testosterone receptors, exogenous testosterone or testosterone given in any form can cause some growth of the prostate tumor. So if somebody's taking any sort of androgen deprivation therapy, that would make me think that they have a history of prostate carcinoma, in which case they would not be a candidate for testosterone supplementation.
Let's see here. Looks like that's it for the questions. Yeah, I think we're all done with questions.
Nancy, thank you so much. Thank you for being there, my little guardian
Thank
angel.
you. Oh, thank you. This is a wonderful, wonderfully educational presentation. Beautiful presentation for your patients. I thank you for doing this for your patients. And thank you, everyone, for signing on this evening. We
Thanks a
appreciate
lot.
your attention. Call Dr. Joseph as soon as you can and schedule your appointment for your consult and start your pellet therapy. Everyone have a wonderful evening.